ايوه كده الصوت عالي.
تمام. الاول انا بشكر حضرتك جدا ان اعطيتني الفرصه دي ان انا اشير معاكم في الكلاب، وان شاء الله تبقى مش اول مره. النهارده ان شاء الله هنتكلم على الاي في سي، not from the echo side, from the assessment of hemodynamics as a fluid responsiveness. Before we starting, we have some objective of the slides, why we are using the IVC and how we will measure and where, and what we are measuring of the IVC and how we can interpret the data, and what is the limitation also of IVC. IVC, it is most is a bigger vein of the body. It is bring more than 70% of the venous return to the heart, and he has also option that his caliber vary with respiration, but we cannot measure IVC in each part in any part of the body. Only in the extrathoracic segment only can be analyzed by ultrasound. IVC diameter and dynamic measurement of its collapsibility, and also we will talk about distensibility, has been proposed as a tools for estimating the intravascular volume status. Because this vein, especially, there is no valve between the IVC and the right atrium. So the fullness of IVC is so correlate with the increased right atrial pressure. IVC used to estimate the preload status and the right atrial pressure, and we can use it as a predictor for fluid responsiveness and to assess also the tricuspid regurgitation severity, and sometimes we are using for assessing the tamponade. What is the fluid responsiveness? Most of the time in ICU, we are asking this patient is responsive or non-responsive to fluid. Patient will get better after fluid challenge, or he need vasopressor or introp, as Dr. Mohamed said in the last lecture. The ability of the left ventricle to increase the stroke volume by 15% in response to fluid administration, this is the patient is a fluid responsiveness. Why we are assessing a fluid responsive in ICU, and how we can measurement, and what is this significant increase? Why are we assessing a fluid responsiveness? As we said before, a patient in critical ill situation or in ICU, it is sometimes difficult to assess his volume status. So we need specific measurement to say or tell us how the patient will get benefit from more fluid, or he need another measurement. Intravenous fluid administration is the cornerstone of resuscitation therapy in critical ill patient. Selection of proper intervention to guide the fluid management is often crucial to avoid the deleterious effect of over or under or inappropriate resuscitation, because over resuscitation with fluid may result in pulmonary edema, and under resuscitation will result in hypoperfusion of the tissue with complication of end organ damage or dysfunctions like renal failure. The Frank-Starling curve, the relation between the ventricular preload and the ventricular stroke volume, or the equation between patient need fluid, more fluid resuscitation, and the increase in the cardiac output, it is not a linear equation, or it is not a linear measurement. It is a curve. Frank Starling, who is the one give us this curve, and we will talk about this one. According to Frank Starling laws, there is a positive relationship between the preload or the fluid responsiveness and the systolic volume. Accordingly, if you increase the ventricular preload, you will stretch more the cardiac muscle, so you will increase the systolic volume or increase the cardiac output. But however, this relationship, it is not linear, but rather as a curve, as most of the physiological phenomena in our body. So a concrete preload value has been reached. Further increment don't give rise to significant additional systolic volume elevation. So here in the curve, you can see here, this is in the diastolic volume or the preload, and here is the stroke volume increase. So down in the curve, If you will give specific volume here, you will give example increase in stroke volume variation or increase in the cardiac output later 18%. But if you will give the same amount of the fluid in the curve, in the upright or the flat portion of the curve, you will give only variation of 5%. This zone of the more increase in stroke volume, this patient is preload dependent zone. So more fluid you will give to the patient, so he will get more benefit from increasing the cardiac output. But in the flat portion of the curve, the more you give fluid, the less increase in the stroke volume or cardiac output, the more deterioration of the curve, patient deterioration of the patient condition. This zone named preload independent zone. We have a lot of parameters or indices or tools, whatever you say, for assessing the preload. In ICU, traditionally, we are using before the CVB measurement and the blood pressure, blah, 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 the static indices. And we have recently, or not recently, it's a long time ago, is dynamic indices. Okay. We will talk about the static versus dynamic measurement. You can see here the IVC diameter can be used as a static and can be used as a dynamic. That in the static, we are using only the diameter, fixed diameter. But in the dynamic indices, we are using the respiratory variation of the inferior vena cava diameter during inspiration, the expiration, in spontaneous and during the pressure control ventilation. Inferior vena cava static indices or diameter, okay, is poor predictive value, okay, for the as a fluid responsiveness. But the dynamic indices for respiratory variation for inferior vena cava, it is a good predictive value. We will talk about this later in more details. As we said about static parameters like blood pressure, heart rate, urine output, and CVB has been traditionally used as provided us for regarding the intravascular volume status. However, if you will use single parameter to guide you as a fluid therapy or as a responsiveness of the patient, is result in hypovolemia or hypervolemia. Even if you will use it many times or continuously monitoring, it's still a significant reduction in tissue perfusion may be not recognized. The dynamic parameters these are used as assess fluid responsiveness and guide goal-directed fluid therapy in patients, particularly in shocked patients. Compared with the traditional static parameters, dynamic parameters provide a superior assessment of response to fluid challenge or fluid responsiveness. As we talk about the dynamic indices, we have a lot of parameters of dynamic indices. We will say here arterial waveform like the pulse pressure variation, stroke volume variation, and also we have also the VTI and the IVC in dynamic mode, or as I said in M mode, okay, which vary during inspiration and expiration. But today we will talk only about the IVC, not the other parameters. As a dynamic measurement, it is related to very specific principle in our body. Its name is heart-lung interaction or cardiopulmonary interaction. This is the physiological principle, how it is the dynamic measurement work. During the inspiratory phase of the positive pressure ventilation, intrathoracic pressure increase, passively increasing the right atrial pressure, causing the venous return to decrease and the vena cava to distend. So during inspiration, the inferior vena cava distend in the positive pressure ventilation. If both the right ventricle and the left ventricle are fluid responsive, this lead to decrease the RV output, and after two, three heartbeats, which name is pulmonary transient pressure, which meaning time need to the blood to transmit from the right ventricle to the left ventricle through the lung is named the pulmonary transit time. In preload dependent patients, systolic changes in LV stroke volume and its coupled arterial blood pressure, pulse pressure variation and stroke volume variation are seen, and the magnitude of the change is proportional to fluid response. We will show you graph now what is meaning of cardiopulmonary interaction. Here, explained by Jean-Louis Boule in 2000. Here we have two pressure during positive pressure ventilation. Now we are talking
شاور
about
لو
positive
سمحت،
pressure
شاور
ventilation. Okay,
ايوه.
sorry. Okay. We have now we will talk about two pressure. During positive pressure ventilation, we have two pressure. Increase in pleural pressure and in the same time increase in transpulmonary pressure or mean transmural pressure. Okay. Okay. We will talk first about the right ventricle and we'll talk later about the left ventricle. The increase in the pleural pressure and the transpulmonary pressure in the same time will pleural pressure will decrease the RV preload. The compression from the pleura on the right atrium, so will decrease the RV preload. In the same time, the transpulmonary pressure increase the pressure in the veins of the lung, so will increase the RV afterload. So here, decrease the RV preload and at the same time increase the RV afterload. So the stroke volume from the RV decreasing. This is during the inspiration. This is the red curve here, the inspiration. At the end of inspiration, so the RV stroke volume decreasing. We need time. This is pulmonary transient time, so go through the LV, from the RV to LV. This is the mean the blood pulmonary transient time. This need time, or as we said, 2-3 beats. This is transmitted from the inspiration to expiratory time. So at the end of expiration, the LV preload decreasing and the LV stroke volume decrease. So at the end of expiration, we will find the stroke volume decrease. If you will go again back to the effect of the LV, increased pleural pressure, decreasing the LV afterload, and the pulmonary pressure increasing the RV preload because pushing the blood from the lung to the LV. So decrease afterload and increase preload, so increase the LV stroke volume. So increasing the stroke volume at the end of inspiration. So there is variation between inspiration and the expiration at the end because we are measuring the LV, not the RV. So at the beginning, sorry, at the end of inspiration, the maximum pressure increasing here from increasing the left ventricular stroke volume. At the end of expiration, decreasing. This is the changes between the pulse pressure variation or stroke volume variation. Increase the variation during at the end of inspiration and decreasing at the end of expiration. If you understand this graph, all the dynamic measurement you will understand. This is a principle of all dynamic measurement. It's clear before going to the next slide.
معقدة شوية بس clear.
Okay. This is the principle. All dynamic measurement of our body, this is the cardiopulmonary interaction. The same example. Okay. If you will mix now the pressure control with the Frank-Starling curve, now we will mix together in two curves. I know this is a difficult curve, but I will talk about it simply. You can see here two curves, Frank-Starling curve, one red and one blue, okay? We said before, if the patient during inspiration, you will decrease the during expiration, you will push the decrease the venous return. So you will decrease the cardiac output. So we would try to imagine this is the red one, the patient during end of expiration, and this is the one end of inspiration. Sorry, I'll come back. You can see the difference between the two curves here by the yellow graph. If the patient is normovolemic, so there is no patient is not fluid responsive, he don't need any more fluid. So the difference between the inspiration, sorry, from the expiration to inspiration is low because there is no difference in the venous return. Minimum, if the patient is mildly hypovolemic, the difference will be increasing. If the patient is hypovolemic, the difference will be increasing. You can see here the systolic pressure variation or the pulse pressure variation, the name equation. If the patient is shocked, here the difference will be more appear. If the patient is mildly fluid responsive or not hypovolemic, the difference will be less. If the patient is overloaded or don't need any fluid responsive, there is no difference between the inspiration and the expiration. This is meaning the inspiration and the expiration pulse pressure variation. This is also another example. This is the pulse pressure variation during inspiration and the expiration. Now we will talk about only the IVC because our lecture is talking about the IVC as a dynamic index. Again, during inspiration of the mechanical ventilation, now we are talking about pressure control, increase again the pressure, the pleural pressure is transmitted toward the right atrium, reducing the venous return and dilating the IVC. In contrast, during expiration, the decrease in intrathoracic pressure favor the venous return and reduce the IVC diameter. So during inspiration, in the pressure control, the IVC will distend. During expiration, the IVC will reduce. This variation between inspiration and expiration increase in the hypovolemic patient, but buffered or cannot be measured in the hypervolemic patient because already the IVC already distended or less distant. Now we have inferior vena cava distensibility. We have to remember this item or term. Inferior vena cava distensibility during pressure control ventilation. Inferior vena cava collapsibility during spontaneous breathing. Assessment of the IVC distensibility index in mechanical ventilation patient provide a useful and reliable tool in predicting response to volume in critical patient. This is another in Shock Journal 2019. They give us the value of what is the difference between IVC diameter here and IVC distensibility index variation. The IVC diameter only is fixed number 1.43 centimeter with a predictive value of positive fluid responsiveness with 90% specificity and 67 sensitivity. While if we will use the delta distensibility index variation during inspiration and expiration as a predictive value with 40% specificity and 97 sensitivity. IVC diameter and also his collapsibility or distensibility give us a clue sometimes about the estimated right atrial pressure. So if the IVC diameter in centimeter as a static measurement below 1.5 centimeter, this meaning there is collapsed or small, during inspiration here as a dynamic measure is collapsed. Okay, so estimating that right atrial pressure or the CVP is 0 to 5. If we 5.5 to 2.5, here the patient is a IVC collapsibility more than 50%, now estimating between CVB to 5 to 10. If more than 2.5, it is mean distended, so the collapsibility below 50%, so the estimated CVB or right atrial pressure between 10 and 15 as a result. How we are measuring the IVC? Anyone who didn't use echo before or not expert with echo, he can use only the probe by simple maneuver to assess the IVC, even he don't have any knowledge about the echo. We will see how. First, the orientation. What probe we are using? We are using the echo probe or microconvex probe. Your patient have to be in the supine position. You have to put window. We have a lot of window in the echo, but we are using only the subcostal window or subxiphoid window. Adjacent to the right atrial, 2 to 3 centimeter. We will show you how now. Measuring below the diaphragm, 1 centimeter before the hepatic vein. And you have to keep your wall is parallel. Now you can see here, this is the subxiphoid or subcostal view for the IVC. This is the diaphragm. The white one is the diaphragm. This is the liver, and this is the hepatic vein. First of all, you have to get the subcostal view, and you have to keep all the time the right atrium view in your screen. And now the liver, you will see the IVC going and end at the right atrium. If you will measure 1 centimeter before the hepatic vein or 2 centimeter or 3 centimeter before the right atrial, this is the specific site for measuring the IVC here. Okay, as a static measurement or during the M mode. You will put the cursor and measuring by M mode. Here the diagram showing the patient position here, as I said, have to be supine, okay, because the abdomen have to be relaxed, so that the patient is supine position, and in subcostal view, okay. This is the diagram also, as we said, is the liver and the IVC in the right atrium. Okay. If you are using the echo and you are using for the viewing the subcostal view, you have to know that we have indicator of the probe or transducer. The mark have to be at the 3 o'clock of the patient, out towering to the left arm of the patient. So first you have to get first the subcostal forehead chamber view, okay, and the pointer to the 3 o'clock or to the left arm of the patient. After that, you rotate your probe anti-clockwise, so keeping the cursor from the 3 o'clock to 12 o'clock, 90-degree anti-clockwise, so rotating to 12 o'clock. Now the pointer to the up, and you can see here the atrium and the IVC passing the liver, and this is the hepatic vein. After you putting the cursor, as we said, 1 centimeter before the hepatic vein, and you can shift from B mode to the M mode, okay? This is the measurement of the IVC during inspiration if the patient on the mechanical ventilator. So we have minimum diameter and maximum diameter. As we said before, the IVC distended during inspiration in mechanical ventilation and collapsed or become minimum measurement during a expiration, and the opposite in the spontaneous breathing. Here, the probe in the subcostal view, patient is supine. The pointer to the 3 o'clock or the left shoulder or left arm of the patient. This is the subcostal view. is right ventricle, left ventricle. Now we will rotate the probe anti-clockwise 90 degree to 12 degree until we see the IVC, barrel wall, hepatic vein, and the right atrium, diaphragm, and liver. Sometimes you have patient coming post-operative, or he has a trauma in his abdomen, or he's obese, or he has a scar in his abdomen. You cannot assess the IVC from the subcostal view. We have alternative is the transabdominal or the lateral view, but we are not using here the microconvex view. We are using the abdominal probe because the abdominal probe is high more penetration. So we are using in the left, sorry, in the right axillary, mid-axillary line and the pointer to the head. Here, different, you can see here the IVC passing through the diaphragm to the right atrium below the, sorry, passing through the liver, under the diaphragm going to the right atrium, and you can see here also parallel to the aorta. When we are using this one, as we said before, patient has contraindication for the subcostal view. Here is the subcostal view, as we said before, right atrium, and this is another alternative for anterior axillary view is the heart IVC. If the patient has large anterior thoracic or abdominal surgical indices during the post-operative thoracic or post-CABG, anterior abdominal pain or distension, when the subcostal view is limited in obese patient. What we are measuring here as a dynamic indices, we say the respiratory variation of the inferior vena cava. Here is spontaneous breathing. As we said, we have collapsibility index in spontaneous breathing and distensibility index in the pressure control breathing. Here is in spontaneous breathing. During inspiration, there is negative pressure in the thorax, so we are sucking the venous return from the IVC, so the IVC will collapse or become minimum measurement in the inspiration and will distend during the expiration. So this meaning is spontaneous breathing is collapsibility index, the maximum diameter minus the minimum diameter divided by the maximum diameter. Okay, we have to be caution here because the two equation will be different in this part. Okay, so the spontaneous breathing or collapsibility index will divided by the maximum IVC diameter. We explained this one already. Here is a diagram showing the difference between the spontaneous breathing and the positive pressure ventilation. Here is spontaneous breathing, the IVC, inspiration, collapse, and expiration distend. The opposite in the positive pressure ventilation. During inspiration, the IVC distended and the expiration will be collapsed. The respiratory variation in the diameter of the inferior vena cava, delta diameter of the distensibility index, have been shown to predict the response to fluid in patient with circulatory failure. This variation in diameter of the IVC are more evident in hypovolemic patient and appear to be buffered in hypervolemic patient when the IVC is less distant. As we said before in the collapsibility index, we are divided the equation by the maximum, but here we are divided by the minimum or the mean. So the maximum minus the minimum diameter divided by the mean or the minimum. This is the distensibility index. Here during positive pressure ventilation, during expiration is collapsed, during inspiration is distended. Here is a diagram showing the difference between the spontaneous breathing and the positive pressure ventilation at the same time. As we said here, Inspiration will be collapse, expiration will be distend, and there is the opposite in the pressure control. Here is the equation and the difference between them. In the collapsibility index, we will divide it by the maximum. By the distensibility index, we will divide it by the minimum or the mean. Now we will interpret our data. In spontaneous breathing, as we said, or distensibility, collapsibility index, more than 40%, the fluid responsive patient may be fluid responsive. May be fluid responsive. If the collapsibility index below 15%, sure patient is not fluid responsive. This is spontaneous breathing for dynamic and distensibility index. But you have to be cautioned during the mechanical ventilation. The patient have to be sedated with tidal volume more or equal than ml per kg, 8 ml per kg. Because during sometimes we have limitation like in ARDS patient or right side heart failure patient, there is peak pressure or low tidal volume, so we cannot interpret it because it will affect the tension of the IVC and its distensibility. We have here cutoff value. If the distensibility index more than 20%, likely patient will be fluid responsive. Is if below 10%, the patient for sure is not likely to be responsive. We have a lot of study talking about the IVC distensibility index and his cutoff value. They mention if we are using in the equation divided by minimum, so the cutoff value will be more or equal to 18%. But if we will use the mean here, the cutoff value will be 12%. So our cutoff value is 18 or 12% in distensibility index, while in collapsibility index 40 or 50%. We have clinical trials, we have clinical trial before they suggest that the respiratory change in the IVC diameter is an accurate predictor of fluid responsiveness with a threshold of 18% differentiating responder from non-responsive patient with 90% sensitivity and 90% specificity. We can now interpret our data. We will give example how is the IVC. Here we have IVC and another example here, and we have another example. We can see here the diameter is like normal diameter. Here, in comparison with this one, is distended. Here, the IVC is collapsed. This is by eyeball without measurement. Okay. Another one. This is a normal IVC diameter. Here, collapsed. And these two distended.
وضح what this means على الفات يعني الكولابسد هايبوفوليميك والديستندد
Okay.
هايبرفوليميك.
The normal diameter here, the patient is a normal person. Okay, no need for more IV fluid. Here, the IVC is collapsed. So the patient is hypovolemic, he need more fluid, or the patient is a fluid responder. Here you can see the IVC distended, but this is a static measurement, not a dynamic measurement. So if the patient already on a mechanical ventilator with high pressure, or already the patient has right side failure or severe tricuspid regurg or even tamponade, the IVC already distended. If you are using the static measurement only as a diameter, so you can mislead that patient may need fluid. So it is better for us to use the dynamic measurement as a distensibility index. So will give you more clue if this patient is responder or not responder. So as we said, again, don't rely on the static measurement. Try to use more than dynamic measurement. A limitation of the IVC, as we said, if the patient on the mechanical ventilation with low tidal volume or high beep or high plateau or low compliance, or patient is tachypnic, you have to keep patient, or if you will use the dynamic measurement or IVC distance ability, so you have to keep patient on sedation. Not all patient you can give him sedation even in the ER or emergency department. If you want to assess the shocked patient, you can use the collapsibility because you no need to put the patient on the ventilation. I also, if you have abdominal surgery patient, so you have to go to the lateral view, not the subcostal view. If the patient with elevated intra-abdominal pressure, intercompartmental syndrome, so it is difficult to assess the IVC because already there is compression from outside. If the IVC compliance vasopressor, because if you are using high dose of vasopressor like norepinephrine, it will push more reserve of blood from the splenic area of the patient, so will give you false data about the IVC. Also, the right heart dysfunction because increasing the increasing the IVC pressure. Also, tricuspid regurgitation and pulmonary hypertension, all of and the tamponade give you misleading about the IVC. So you have to use another parameters than the IVC. Also, one of the example of the poor subcostal windows that IVC has limited. Here is IVC is subcostal view. You cannot see anything. Also here, you cannot differentiate between his liver and the diaphragm. You cannot see the IVC here. I will show you short video for how to assess your IVC easy. Here the patient is supine, as we said. You are putting the probe and the transducer pointer to the left shoulder, 3 degree, and rotating again to 12 degree, 12 o'clock, and you can see here tilting your probe until you see the right atrium and the IVC and the liver. This is the subcostal view, right atrium, hepatic vein, and the IVC. Another short video also here using the abdominal probe. Here you can see here is IVC, liver, change of the diameter during inspiration and expiration. See, during inspiration, in spontaneous breathing, the IVC collapsing. Right atrium, this is the measurement in static mode. Reduced during respiration is meaning more fluid responsiveness. Summary, it is very easy to you are using for assessing the IVC, even you are not familiar with the echo. Give you by eyeball estimating the feeling status if your patient is not on the ventilator or not sedation. It is non-invasive like elevation of the IVC, more informative than the IVC. The dynamic index is a predictor of the fluid responsiveness, but you have to be in cautions. And sometimes there is limitation, and it is not comprehensive exam. Okay, thank you. And
شكرا
if you
جزيلا
have any
دكتور
question,
محمد على المحاضرة الهائلة دي اللي انت امتعتنا فيها بالفسيولوجي
thank you.
والميثودولوجي والفاليو اوف different method of fluid response مع التركيز على الانفيريور فلتر. هنفتح باب مناقشة، بس أنا أول بس سؤال. هو دلوقتي لما أنت بتقيس الكولابسابيلتي أو السنسبيلتي بتعتمد على إنك بعد ما تجيب المنظر اللي أنت قلته لنا في التو ديز بتاخد ام مود وتقيس الفاريشن ما بين الانسبيريشن والاكسبيريشن.
بالظبط كده. لو هقيسه في البي مود هقيس static measurement only. If I will use the M mode, I will see the variation during inspiration and expiration.
اوكي، عايزين نسمع بقى الأسئلة من الحاضرين. المحاضرة أطلبك. شكرا حسن.
الحمد لله.
طيب السبونتينيوس، يعني أنا برضو شايفك
مم.
مركز على كل الانفيريور كافال كولكسبيليتي
with
او
distance
اكسسبيليتي، متاسف،
مم.
في عينين الميكانيكال فنتليتر. لكن لو انا
تمام.
بقول لك انا عايز تقول لي اهميته في العيان سيبتك شوك ومش على فنتليتور، الفاليو بتاعت الانفيريور كافال كولكسبيليتي قد ايه في الاسسمنت؟
في الكات اوف فاليو في الكولابسابيلتي if the during variation of collapsibility index more than 40%, mostly the patient is over the volume depleted and he need more fluid. If the collapsibility index below 20%, so this patient mostly not need more fluid, instead he need any drops or vasopressor.
طب مال 18% دي بتاعت مين؟
Distensibility index.
دي بتاعت الميكانيكال فنتليتور.
ايوه دي الميكانيكال فنتليتر. البيشنت
اللي
have to be
اقل من
sedated.
18؟
طب اقل من 18 يبقى patient not indicated for fluid. More than 18 patient is fluid responsiveness.
أوكي. مين من
This is the
الحاضرين عايز يسأل يا جماعة؟
thank you.